All right, this case is about a case of new onset right bundle branch block. I had this case up before, but I watched it and there were some things I left out, so I'm going to redo it. This case comes from Dr. Marissa Matthews. She's one of the EPNO attendings. These are the glamour shots that they make us get. Hers is pretty sick. I mean, you can see you got like backlight, sunlight coming through here, nature in the background. Looks like a dope senior picture. Here's mine. I went with like the constipated face. Like I'm a psychopath and I don't know how to smile on command, and they were like, smile. So I was like, let me just move my face symmetrically upwards. But let's get on to the science. All right. So this was the case that she had chest pain. The patient arrived to the EDVM EMS with complaints of chest pain. Patient was discharged from the hospital today from back surgery and started having chest pain tonight, 2 hours prior to arrival. Patient states the pain radiates to his left arm, reports some nausea and dizziness earlier. As far as past medical history, he's got a history of atrial fibrillation, hypertension, and a previous STEMI, as well as obesity and type 2 diabetes. Remember, the value of any test depends on your pretest probability, and thus the value of any EKG depends on your pretest probability. The history and the risk factors is what gives you your pretest probability for the EKG. So for this patient in particular, I'd say there's a relatively high pretest probability that he's got something going on, correct? Now remember, it's always good to establish a baseline when you're looking at an EKG, okay? And this is this patient's baseline EKG from 8 days ago. Okay, pause, write down what you think, and give me your interpretation. All right, before we go on to what I think, I looked up the definition of interpretation, and it's the action of explaining the meaning of something, which I think is germane to what we do. Because remember, my thought process is on EKGs, you can see many abnormalities, but you have to have symptoms in order to qualify for pathology. Like abnormalities on an EKG with symptoms equals pathology. Like if you have the abnormalities and no symptoms, there's not always pathology. So here's what I see in this EKG. Number one, the rate appears to be irregular from his underlying atrial fibrillation that we know about. Number two, the axis is left deviation. It's up in 1 and down in AVF. Number three, there are diffuse nonspecific ST wave abnormalities, but I don't see any acute signs of infarction or ischemia. And for me, anytime you're worried about infarction or ischemia or ACS, always compare the J point to the PR segment. So when we go through this EKG and look around, there's not too much J point deviation from the PR segment. There is poor R wave progression, which is to be expected in this gentleman because he has coronary artery disease. The definition of poor R wave progression is an R wave less than 3 millimeters in V3. He also has an underlying left anterior fascicular block. It's up in 1 and up in AVL and down in 2-3 in AVF. So that's my overall interpretation for his baseline EKG, and I would say it's non-diagnostic. So here's the EKG at 20:56 when Dr. Matthews saw him. Okay, again, pause, write down what you think, and give me your interpretation. All right, so there's many things on here. Okay, number one, the rate again appears to be atrial fibrillation. Number two, we still have the left axis deviation. But number three, if you notice, we developed a complete right bundle branch block appearance. Okay, it's greater than 120 and it's upright in the precordial lead, so that's consistent with a right bundle branch block appearance. In addition to the right bundle branch block, we also have this underlying left anterior vesicular block. It's still down in 2-3 in AVF and up in 1 in AVL, so that's a bifascicular block. Now, the right bundle branch block always gives people issues, in my opinion, because throughout my career, I've seen it either overcalled or undercalled for ACS, and it's because people lose sight of where the J point is. So my recommendation for right bundle branch blocks is when you're looking at the J point, find a QRS where you know the duration of the QRS is and extrapolate it out, okay? Remember, all of these beats are the same. So this beat right here in V1 is the same as V2, is the same as V3. Right here in V1 on this big red line, you can conveniently see the J point matched up with that. So the QRS starts here and ends here, and here's the J point. In V1, it's slightly depressed from the PR segment, which is what we would expect. But when we follow it down, there's definitely J point elevation from the PR segment around 3 to 4 millimeters here. There's J point depression here as well. If we go to the other leads and map out the J point and map it down, we can see there's significant J-point deviation in multiple leads. Here's a close-up of that like I was talking about. So we map out where the J-point is, follow it down. You can see there's ST elevation in this lead. Same thing over here. AVR ends on this big red bar. So when we follow it down, there's about 4 millimeters of J-point elevation in AVL and about 4 millimeters in J-point depression in AVF. Same thing with this one. Here's lead 1. When we follow the J-point down, we can see there's J-point elevation in lead 1, depression in lead 2, and depression in lead 3. Same thing over here in 4, 5, and 6. You can see there's about 4 millimeters of J-point depression in these leads. Same patient just a few minutes later. This is at 2101, and we see the same abnormalities. Okay, it's a little wonky here from motion artifact, but we have the same problems. Okay, we have the bifascicular block. We have the J-point depression in multiple leads with J-point elevation in other leads. Same patient just a few minutes later, because part of the STEMI protocol at this hospital is we do EKGs every 5 minutes until they go to cath lab. And you can see here we have the same abnormalities, but the morphology of the ST segment has gotten more concerning. You can most see it in lead 1 in AVL. Like when we go to the previous EKG, yes, you see there's J-point elevation, but the morphology of these ST segments are more rounded. When we go to the subsequent one, we can see the linearity of the ST segment. Okay. Remember, and this is just one of my rules, like the EKG is not like a straight line. Anything straight on an EKG outside the baseline is supposed to be as narrow as possible. Like that's why a narrow QRS is normal and a wide QRS is pathologic, because it's more of a straight line acting for more long of a time. I mean, just look at this. Like this line is straight and it's like over half the amplitude of the QRS. That's highly concerning for pathology. So he goes to emergent cath, and of course, he's got an occlusion. Okay, complete thrombotic stent occlusion of the distal LAD. You can see how bad this disease is and how there's no flow going to the heart. Unfortunately, this gentleman ended up passing away at midnight. And you can see, like, from when he first came in, like his first EKG was around 11 p.m. And unfortunately, an hour later, he had passed away. I mean, it just goes to show, like, how bad these pathological findings are on these EKGs. So let's go into what the literature has to say. Okay, this is from the American Journal of Emergency Medicine from January 2026. Here's the highlights. New right bundle branch block with ischemic symptoms equals high risk and consider urgent reperfusion. Concordant ST elevation in leads is a specific sign of occlusion even with right bundle branch block. Excessive discordance, ST elevation proportional to QRS, increased suspicion, uses Smith-type proportionality logic. I don't like these two terms, concordance and discordance, with a right bundle, okay? Remember, concordance and discordance is only for Sgarbosa's criteria, and we only use those for a left bundle branch block or a ventricular paced rhythm, okay? In my opinion, when you're talking about a right bundle branch block, don't say concordant and discordant, just say elevation and depression. Because Sgarbosa's criteria is confusing enough. Don't try to apply those criteria to things that it doesn't not used for. Okay, so reserve those terms only for left bundle branch block or ventricular paced rhythm. And again, the most commonly implicated vessel is the proximal LAD. From the same paper, newer presumed right bundle branch block, which our patient had, with ischemic symptoms, which our patient had, treated as a STEMI equivalent. It often reflects proximal LAD occlusion. Right bundle branch block has associated with higher mortality than left bundle branch STEMI equivalent. And Dr. Matthews did a good job. Like, she called him a STEMI, like, right away. Like, she knew what she was doing. New onset bifascicular block with right bundle block and left-hand fascicular block, which we had, is highly associated with proximal LAD occlusion, which we also had, and negative outcomes, which we also had. Here we go. I don't know why I put this in here twice. Probably because I'm a moron. That's why it's so important. I put it in there twice. From the same paper, proximal LAD most commonly indicated when right bundle branch block appears. Left main or multi-vessel disease may also present with conductive disturbance, including right bundle branch block. Conclusion, new onset right bundle branch block in the setting of chest pain is high risk, which we saw in this case. Let me go back to one thing. So I say all the time, the trifecta for me, for someone who needs to go to the cath lab, is symptoms plus risk factors plus a focal repolarization abnormality. Now, when we look at this EKG, we almost have a global reperfusion abnormality, correct? And with the exception of AVR, in every lead, there's J-point deviation. Like there's J-point elevation in 1, depression in 2, 3 in AVF, elevation in AVL, V2, V3, V4, V5, V6. Almost every lead is affected. Again, in my opinion, throughout my career, when you see someone who's super sick and has a global reperfusion abnormality, it's usually one of 4 things that I'm worried about, okay? Number 1 is coronary artery disease. And when we're talking about coronary artery disease in this situation, in someone who's super sick and has global repolarization abnormalities, the question is it a type 1 or a type 2 infarct? Type 1 means there's an occlusion of a vessel, as we see in this gentleman, right? Like he has an occlusion that needs to be fixed with a cath lab. However, I often see this global repolarization abnormalities in people who are having a type 2 infarct. Specifically, people who are unhealthy, like old people from a nursing home where they have underlying coronary disease, and there's a stress on their system. The 2 most often I see is either they're septic or they have a GI bleed. So they come in and they're septic or they're severely anemic, and they have this global reperfusion abnormality, and some of the residents are like, oh, it's a STEMI, we just do the cath lab. No, that's not the case. Okay, remember, you don't treat an EKG, you treat a patient, and the global reperfusion abnormalities, first thing I worry about is coronary disease, and the question is a type 1 or type 2 infarct. For the second thing, you got to think about toxic abnormalities, specifically medications, either medications that you take or street drugs, specifically anything that affects either the sodium channels, the potassium rectifier channels, or connexin 43, like antipsychotics, antidepressants, cocaine, methamphetamines, Rhythmol, propafenone, amiodarone, anything that affects those channels can cause this same appearance. Number 3 is metabolic abnormalities, and specifically in my experience is either extreme hyperkalemia or extreme acidosis. And number 4, left often associated, is severe brain injuries, either like a huge ischemic or hemorrhagic stroke. So remember, you see someone who's super sick with global reperfusion abnormalities, think those 4 things: coronary artery disease, toxic problems, metabolic problems, or issues with the brain. And remember, if you're suspecting coronary artery disease, distinguish between a type 1 infarct and a type 2. All right, let's go back to the literature here. So here's what I'm talking about. This is from a paper online where they sent them to the cath lab, but they didn't need to. And again, it's because they didn't extrapolate out the J point. And that's what they're mapping here. Like they were suspicious, oh, this is ST elevation, but no, it's not, because it's still within the QRS, right? And this is a good example of what a normal QRS or normal right bundle branch should look like. Okay, a couple things. Number 1, if you notice in the precordial leads in the right bundle, it's normal and or okay to have slight ST depression and T-wave inversions. Let me say that again. In a right bundle branch block, it's normal to see slight ST depression and or T-wave inversions in the precordial leads. That's a normal finding, okay? The other thing is you should not be seeing an axis deviation in a right bundle branch block, okay? Having an S-wave in lead 1 is part of the diagnostic criteria, but the S-wave is always shorter than the R-wave and wider than the R-wave. So these things are what you should expect to see in a right bundle. Remember, slight ST depression or T-wave in precordial leads is to be expected, and you should not be seeing an axis deviation, right? So like I was talking about before, I mean, the literature tells us that new onset right bundle is bad and can be associated with coronary artery disease, but it can also be associated with a pulmonary embolism, okay? And it goes back to what I was talking about before, is we don't treat an EKG, we treat a patient, right? So you have this abnormal EKG, your interpretation or what the meaning of it is depends on what they're here for, right? Like our gentleman, high risk for coronary artery disease, like that's what it turned out to be, but we'll go over some other cases here. And again, here's some literature, you can read this at your leisure. New onset right bundle was associated with a heavy PE burden. Same thing for this one, and again, you can read through it or go online and look it up and look through it more if you want to. Here's some cases I had throughout my career that highlight this new onset right bundle and PE association. This is a 7-year-old female with COPD. She was tachypnic, unable to have productive speech, not wearing oxygen, and she's hypoxic, okay? We have no previous EKG to look at, and again, we have these same abnormalities, right? Number 1, we have a complete right bundle branch block appearance. Number 2, we do see T-wave inversions in the precordial leads, but again, we see this J-point deviation, which we're not expecting to see, right? Like the J-point should be slightly depressed in a right bundle branch block. And here it's about maybe a 0.5 millimeter elevated from the PR segment. You also see that same abnormality in AVR. And again, look, we have an axis deviation. Like it's pretty close, but the R wave or the S wave is bigger than the R wave in lead 1, giving us an axis deviation, which we shouldn't see. For this case, she actually came in as a STEMI alert because EMS was concerned about elevation in AVR, V1, and V2, which there is. But again, the value of any test depends on your pretest probability, and the history guides us as far as what we should be concerned with this patient. So we sent her the CT scanner, and again, she's got a large PE burden that needed to be fixed. This was her repeat EKG when she got to Toledo prior to her thrombectomy. And again, we've seen these same conduction and repolarization abnormalities, right? Like now we have a wide QRS with a right bundle branch block appearance. Same thing, we have this T-wave inversion of the precordial leads. But when we map out the J point here in lead 1, which is on this line, and we follow it down, we see there's like 4 millimeters of J point elevation. Similar here in these leads in AVR, there's J point depression. Same thing in AVL and J point elevation in AVF and lead 2, right? And again, we're seeing like this large R wave here. Again, this could, look like a infarct in the proper situation, but again, we're seeing this is from a pulmonary embolism. Another case I had before, 59-year-old male presents ED for respiratory problems. Short of breath this week. He's got a cough. He gets short of breath when he walks. Says he's never had a blood clot, no recent surgeries. Here's his EKG, and again, the same problems. All right, we have the complete right bundle branch block. And we have this J-point deviation, specifically the elevation in lead 1, which we should not expect to see. Like, yes, we have these inversions, but we shouldn't be seeing this J-point deviation in V1 and AVR as well. Excuse me. And again, look at this axis deviation, right? Like it's down in 2-3 in AVF, up in 1 in AVL. We also have this new bifascicular block. Like that's something you should not be seeing normally in a right bundle. And of course, we scanned this gentleman, large PE burden that needed to be fixed. Once again, another case, a 90-year-old lady who comes in weak and short of breath. Here's her previous EKG, and the quality's not so good, but the main thing to note is there's no axis deviation, and we do not have a right bundle branch block. Here's the EKG when I saw her, okay? Number 1, complete right bundle branch block. Number 2, look at these precordial leads, okay? Again, like I stated before, T-wave inversions and slight ST depression is to be expected in the precordial leads. But just look at 2 things. Number 1, the morphology of these ST segments, okay? Like, see how scooped they are and abnormal appearance? That's indicative of right-sided heart strain, especially the precordial leads. And again, they mentioned before in that paper, like the Smith-type proportionality rule. Steve Smith's rules for Sgarbosa's criteria is that the discordance should not be more than 1/4 the amplitude of the QRS, and that's a change from the 5 millimeter rule. This proportionality type thinking I think is important and comes up again and again in EKGs, right? Like a pathologic Q wave is greater than 1/4 the amplitude of the QRS. For me, linearity of the ST segment greater than 1/4 of the QRS is concerning for like infarction or ischemia. And again, we see that here. Like this J-point depression here is only maybe like 3 millimeters, but that's definitely over half the amplitude of the QRS here. And again, so we sent this lady to do CT scan, and she had a large clot burden that needed to be repaired. Here's what I'm talking about for the fascicular blocks. Okay, there's many different ways to remember this. I have my own tricks that I can show you in person. It doesn't make sense for me to explain it over the internet. But a left anterior fascicular block is down in 2-3 in AVF and up in 1 in AVL. Left posterior fascicular block is pretty much the opposite. It's up in 2-3 in AVF and down in 1 in AVL. If you'll notice, like part of having a fascicular block, part of the criteria is you have to have an axis deviation. Okay. And that's what I was talking about. Like for a fascicular block by itself is not really concerning to me. Like a new onset fascicular block can be associated with coronary disease when you look at the literature. But for me, the main reason I'm worried about a fascicular block is when I see in conjunction with a right bundle branch block. Okay, because as we saw in the case from this week and what the literature says is a new onset bifascicular block is highly concerning for coronary disease. Okay, in my career, I also am concerned about bifascicular blocks when you have syncope, okay? Whether it's new, whether the bifascicular block is new or old, if you have that with syncope, it's also concerning. I mean, because you'll see lots of bifascicular blocks and people walk around their entire life with bifascicular blocks and they have no problems. It's when it's causing syncope or new onset with symptoms is when it's concerning, all right? So that's all I have for this case. Let's just review the key teaching points, okay? Number one, new onset right bundle branch block. It's concerning for either coronary disease or pulmonary embolism, right? Number two, new onset bifascicular block, highly concerning for coronary disease, specifically the left anterior descending pathology. Number three, you should not be seeing a fascicular block in a right bundle branch block. You should not be seeing an axis deviation in a right bundle branch block. The number next is that it's okay or to be expected to have slight ST depression or T-wave inversion of the precordials with a right bundle branch block. The other thing I brought up from this case, remember, it's a diffuse repolarization abnormality. When you see a diffuse repolarization abnormality who's someone who's super sick, think those four things. Number one is coronary disease, and the question is it a type 1 or a type 2 infarct? Number two is toxic things, be it prescription drugs or street drugs. Number three is metabolic processes, specifically hyperkalemia or severe acidosis. And number four is significant brain trauma and or pathology. That's all I got. I hope you enjoyed it. If you have any questions, ask me in person. Peace, I'm out.